I wanna live outside of all of this.
Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school.
Welcome to the Inside the Boards podcast. I am Patrick Beeman, your host. This is a representation of our 2017 Study Smarter series episode with Dustyn Williams from OnlineMedEd, covering endocrine questions. As you've listened to the Study Smarter series this year, I just want to thank you all for your support. I hope that it has been helpful during your Step 1 dedicated prep. If so, please tell your friends, especially the incoming first years or those starting second year, to stay tuned to what we're doing both on this channel, the Study Smarter channel, and the main Inside the Boards podcast channel. Come late August, we will be doing a Step 2 Study Smarter series, and I do want to just kind of update you with respect to the Inside the Boards All-Audio Qbank. As you know, probably, the first year edition is powered by Lecturio and Osmosis. The third year or clinical version is powered by OnlineMedEd. We are rapidly increasing the amount of content that we're putting up, finally, and because of that, I am going to offer a 12, 18, or 24-month subscription to the All-Audio Qbank. For our early supporters, you can get a 33% discount on this beta version. So what that essentially amounts to is 12 months of access for $50, 18 for $60, or 24 months for $70, which is a pretty decent deal, I would say. Just click the link in the show notes to this episode, or go to our website, insidetheboards.com/Qbank, and at the top left of the page, there is an ITB All-Audio Qbank button. If you click the drop down and hit the 12, 18, or 24-month option, click Sign Me Up, open the Show Order Summary tab, and inputting the discount code Study Smarter, you will get 33% off the long-term subscriptions to our All-Audio Qbank. And once we get an app out, you will get free access to that as well. And that should be no later than the 1st of January, with our hope being that we're able to get out a beta version of an app to make the content delivery much more smooth within the next 3 months. I know that whole checkout process is a little clunky, so it's probably best just to click the link in the show notes. As always, thank you so much for listening and for supporting us. I sincerely hope that the start of this academic year is your best year of medical school. Enjoy. So, Dustyn, thanks for coming back.
Yeah, my pleasure. I like this podcast.
Well,
I'm probably going to do a few more after this.
Absolutely. Yeah. I would be so honored. How's the cat doing?
The real cat is doing great. She's a little lonely with all my travels, but the OnlineMedEd cat's doing fantastic. We actually just hired a marketing firm, and the dude who runs it loves cats. So I'm finally winning the war between Jamie and I. There's definitely going to be more cat.
All right, let's get into this. What do you do? What did you do when you were preparing for Step 1? How did you approach questions? Do you have a systematic approach, or do you just kind of take it as it goes?
To be honest, I actually studied using the Kaplan videos, and I could not bear to stand Golian, so I couldn't use Golian, and Pathoma didn't exist. So Step 1, UWorld, Kaplan videos. And that actually did really well for me because I was able to practice. And at the time, I did it wrong, right? I did it the way everyone else does, which is read the vignette, read the question, read the answers. I've learned since then how questions are written, and therefore how you should actually take them. And I've actually created a method for success. It's on OnlineMedEd, the next level methods for success. It's a free video. There's no paying content. It's all free stuff to read about. And it's basically what I learned from Jeff Weiss. He made us write questions as a means of teaching residents how to take board-style questions. And actually, it was really interesting to figure out the methodology. And I don't say this to brag. I say it to prove a point. And even my residents at the internal medicine residency program in Baton Rouge still won't do it my way. I think they think because it sounds stupid. But I took my ABIM board exam and finished in 2.5 hours. And I'm board certified, so I passed. It's a 9-hour test, right? And by the time some of my classmates that just graduated residency with me were taking their first break, I was leaving. And I studied a lot, and I worked hard on OnlineMedEd, so I know a lot of stuff, but it's not the knowledge that helps you. What I learned was how to write a question, and therefore I learned how to take a question. And I'd actually like to spend a couple of minutes just explaining it.
Absolutely. That is the whole reason I call us inside the boards, because the goal is to teach students to think like question writers, because I myself was a mediocre test taker, a standardized test taker. And then once I started writing and then editing like thousands of questions, there's a certain facility you get in answering questions, even apart from knowing the content. And despite the NBME and NBOME trying to avoid having questions that can be answered or answer choices that can be whittled down through test wiseness, there still is a lot of test wise principles that you can learn to improve, I think, your score. Focusing, I guess, on the how more than just the what. So yeah, absolutely. Let's hear it.
And actually, I think that I hate the USMLE that it's used as a way of getting people into residency and like valuing a human or a doctor against each other. But I do think that the USMLE actually does a really good job. If you're going to standardize and automate a test-taking process for physicians, they do a pretty good job, right? Because there are no accepts, no nots, no multiple choice, multiple right answers, no all of the aboves. So there is some test wiseness, right? Because all the questions have to be written under the same principles. It makes it so it's easy to get good at taking the test. And we actually have this in our shelf and step prep guide, which is also free on OnlineMedEd. It says that, how do I want to say this? You have to train your mental faculties just like a competitive athlete will train the rest of their body, right? If a boxer gets in the ring and all they've done is just skip rope, they don't have the strength, the ability to box to keep up. But if they don't do the jump rope, then they're not going to have the endurance to stay in the ring. And part of test taking is doing the thing that you're going to take. Like you have to train for the test.
Yeah.
In doing so, hopefully you learn stuff along the way, but you have to train for the test. And that's part of the game. And unfortunately, if you want to do well, or if you're doing poorly and just want to pass, you can actually get a bunch of points just by playing the game right. Training for the test. So the way we write questions, and you can chime in with your own experience here, basically what happens is that you start with an educational objective, right? The thing you want to test.
Yep.
Side effect of beta blockers. And then you write the question, not the stem, not the vignette, but the question.
Yeah, the actual interrogatory.
Right, like what's the side effect of beta blockers? But then that's a single order question, and all the step questions are hinge questions. So you ask it differently. What medication is likely to cause the side effect? You have to identify the side effect first, and then it's basically asking the same question, what's the side effect of beta blockers? And then the person hits the right answer, beta blockers. And then they will put in other answers that sound right, that could be correct if you alter the vignette in a certain way, that makes all the other answers correct. And they'll choose answers that sound like, or at least might potentially, if all you use was word association, just by doing flashcards instead of actually linking things together, you might recognize a word and associate it, but it's actually wrong. That's a really good distractor, right? And so what I try to do actually is, as I coach these questions, I say, if you can change the vignette to make the other answers right, that's how you know you've mastered the content. So they've chosen educational objective, they've chosen a right answer, they've chosen the hinge questions they're going to ask and all the wrong answers. And then you write the vignette.
Right.
You can take a question that's testing what's the side effect of a beta blocker and compare it to another of other medications. And if you just know what's the side effect is the question, then you just go through and know the other side effects. So if it's hydrochlorothiazide, lisinopril, and amlodipine, well, thiazide diuretics cause hypokalemia. ACE inhibitors cause hyperkalemia, and calcium channel blockers cause peripheral edema. I, as the question writer, can just write a huge vignette, like blah, 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 has bradycardia, blah, 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 blah,
Yep.
blah, right? The blah, blah, blah is there to throw you off. But the other cool thing about step 1 and step 2, which is that they don't throw curveballs on step 1 and step 2.
Right.
So all that blah, 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 blah is actually legit, right? It's like if there's a hinge question and the blah, blah, blah in there is really relevant material.
And I think one of the important things to keep in mind for students, because a lot of people will get an answer wrong, say on a practice question in their QBank, and they'll think, see, they tricked me. I think drilling down to the reason why someone thinks that is really a part of learning what good test taking skills comprise, and knowing not just like what is the side effect of the beta blocker. That's not going to be an actual interrogatory. It's learning to discern what is actually being asked in the question, like, can you sum it up in a giant vignette that says, which of the following is a side effect? I guess the other thing is with the boards, question writers are advised not to include irrelevant material that makes a question difficult because of irrelevant difficulty. So even though a lot of those vignettes are ridiculously long, each thing in there is designed to help you learn to discern and cut through the crap, essentially, train your clinical judgment. So every time I would say you have that sense of, oh man, they were trying to trick me, those are the really important questions you should mark in your review and really drill down, find out why you got it wrong, because you probably can come on to some principle that will help you apply to different questions. I don't know. What are your thoughts on that?
Yeah, that's exactly true. I don't give this lecture anymore because I'm too busy, but I would go around the country giving Acing the Wards, how to present a case and why board exams matter, and was always targeted to schools right as they were approaching step one. And the whole point was that even though it feels like you're studying useless material like the Krebs cycle that you're never going to talk about again, at the same time, in that vignette, they're giving you practice patients. You don't even know it's happening.
Right.
And as you said, they don't include erroneous information. They don't have 4.5 pages to do an H&P. So when they say something's positive, it means something. And definitely they don't have, 8.5 pages to do a negative review of systems. So when they say something's not there, or it's negative, they're taking the time to tell you. That means that is going to be really necessary to the hinge question. It might just be to a diagnosis that you then need to hinge to, or they might really be pushing you away from one of the distractors. And it's really useful. So if they take, if they say the usual stuff, the age, the race, the gender, and the past medical history, kind of ignore that stuff, right? But then if there's talking about the physical exam or the vital signs, or even if it comes down to preclinical science stuff, if they mention something that's positive, or more so when they say it's negative, you're going to hone in on that. Right? And that's actually the strategy I use, right? So I've read the question, I've read the answer choices. I'm already scanning the vignette. I don't care about the blah, blah, blah. I'm looking for the things that I need from those answer choices. And just to illustrate this again, same question about beta blockers. If you got 3 other medications there, well, I'm looking for other side effects. If you've got drug classes, class 1 through 4 antiarrhythmics, well, then it refocuses what you're going to be talking about. And to illustrate this concretely, I know everyone's had this experience unless you've been doing the strategy from the beginning. You go through a vignette. And you're like, yeah, I got this. You're like highlighting left and right. Like you got the answer, right? You got the diagnosis, get to the bottom. And it's like,
oh, that's not what they're asking.
Right. Well, yeah. Wait, what? Right. So if you've had that experience, that's exactly what you've done it wrong. You try to guess what the question's going to be by going through the vignette. And so your brain focuses on all these things that you think are awesome, and you get to the end and you don't need it.
So I guess the first principle then is really to start with what the question writer themselves begins with, and that is the educational objective, right? Not to go the other way around.
Exactly. If you can start thinking like the person who wrote the question by reading the question first, try to figure out what universe you're in, cardiology, nephrology, dermatology, psych, whatever. And then if you can deduce the educational objective by the answer choices, the question's going to take 2 seconds. You're already done.
All right. What else on your approach to questions? So start with the interrogatory, look at the answer choices, then go back to the vignette.
Yeah. And then highlight only the things that relate to your answer choices, right? The positive and negatives, the negatives regardless of what you think. The other thing is people get trapped, right? They see one element of a disorder or of an illness script that they think is really relevant, and then they have all this other competing information. It's actually almost true of what people do in real patients, right? That's a heuristic where people lock in an answer and then block out everything else.
Yeah, Jerome Groopman talks about that in How Doctors Think. Now I forget what the that particular heuristic is called, but Anchoring, yeah,
right. And so you make a decision early on and you stick with it. And then and I've actually had people email me or write in the discuss boards about a question, and they lament that they thought I tricked them, just as you said. And it was, no, I mean, you had all of this other competing information, and then this one piece, which does fit into the illness script for this disease that we're talking about, it also fits into the one that you thought it was, but the other 4 elements are all there that point you away from it.
Because it's a single best answer, right?
Yes, that's indeed, yes. Which I actually, that's why I say, I think the USMLE, if it's going to be automated, it's actually doing it very well. There's only one right answer. And regardless if you think you would do all the things or it might be 2 or 3, there is only one right answer. And you actually have to read, that's why you read the question first. It may not be what's the next step. It may be what's the best diagnostic test. It may be what's the most common cause of death. Not what kills people, but what's the most common cause. Not give the beta blocker its arrhythmia in 24 hours, right? So you have to make sure you answer the question that they're asking. And if you read the question first, that's never even an issue, right? Like, you know what the question is. So like you don't even get distracted by superfluous information in the vignette.
Should we go through some and apply your methodology here?
All right, put me to the test. Giving me step 1 content.
Yep.
Let's see if the master educator test taker can match mental wit with step 1.
And I will say that even though this podcast does take a ridiculous amount of time to edit sometimes, Dustyn has not looked at any of the questions that I'm going to give him. He is doing this like a third-year medical student on July 1st, standing up before a grand rounds audience of attendings, getting pimped on like surgery principles. Except today we're doing endocrine.
I'm ready to go. I'm excited.
All right. So first, a 16-year-old girl comes to the emergency department because of a panic attack. She began feeling tingling around her mouth and then became nervous, causing her to hyperventilate. The tingling has persisted, and she also reports having had muscle cramps and spasms for the past week. A metabolic panel reveals normal electrolytes except for a low serum calcium. A review of the patient's chart reveals thyroid surgery 1 month earlier due to a suspicious nodule. Which of the following findings is most likely to also be present in this patient?
All right, don't read them.
All right.
What's most likely to be found in the following, what else is likely to be found? We had thyroid surgery, low calcium, and she's got tingling of the perioral area and muscle cramps, right? She's got hypokalemia. I thought first it was going to be a panic attack, and I was looking for stuff about albumin and low CO2, but then she's got perioral tingling. They tell you low calcium and thyroid surgery. She's had a parathyroidectomy. So I'm looking for low PTH. So maybe we're going to get into basic science stuff, and then or physical exam findings like Chvostek sign and Trousseau sign. So let's read the answer choices too.
You are so nervous because, like, you know all this clinical stuff for hypokalemia because you're a doctor, but this is step 1 content. You never know what's going to get thrown at you.
I never know. All right, read me the answer choices. Let's see.
Here they are. A, low parathyroid hormone. B, low thyroid stimulating hormone. C, high calcitonin. D, high parathyroid hormone. Or E, high thyroxine.
That would be a really easy question if we did the method. If you read the question first, I would see those options and see, okay, there's thyroid and calcium stuff. And then I just go to the vignette. And as soon as I see thyroid surgery, that's like the buzzword, right? If you accidentally take out the parathyroids and you remove the thyroid, its anatomy, you're going to tank the production of PTH, and low PTH leads to low calcium. The decreased TSH, it's always backwards, right? Decreased TSH would actually mean hyperthyroidism, right? That would be what they're expecting there is a low T4, which would cause an increased TSH because of the thyroid surgery.
So let's look at that. So B, low thyroid stimulating hormone. You might think, okay, so the patient had thyroid surgery, so they're probably trying to tell me her thyroid's out, right? Mm-hmm. So 2 errors here. 1, not, I guess, thinking through where does thyroid stimulating hormone come from, because it actually comes from the anterior pituitary, right? So that would be wrong in and of itself, but I could see how somebody could easily make that mistake if they were just kind of scanning a question and didn't really think through what was, being mentioned. And you see thyroid surgery, think no thyroid, but if you don't read the whole of the answer choice, thyroid stimulating hormone, there is a potential you could get it wrong.
Although actually there's one option that's elevated T4 and another one that's low TSH. Mm-hmm. Oh, and those are immediately out, right? They mean the same thing, right? Like if they're not associated together, like those 2 can just be eliminated right away by test taking strategy. And actually, the decreased PTH and increased PTH is the other option. You've narrowed it down to the 2 there. And calcitonin is a medication that you give. I mean, I don't even know how that works into basic science. Like literally, we get right down to low PTH and high PTH, and you just got to know the anatomy of the parathyroid.
So essentially, after thyroid surgery, calcitonin would likely be decreased or unchanged, since it's produced by the parafollicular cells of the thyroid gland.
Yeah, sure. Definitely. I believe you.
I'm not going to lie. I have some notes on this, so that is not coming from my memory. But I guess I could see, so whenever I looked at like questions when I was writing them or reviewing those from, like feedback from users in the Qbanks I worked on, we'd often see like, okay, 60% or 70% of students keyed answer A, low parathyroid hormone N, as the correct one. Okay. If it were 100%, then we'd scrap that question because that question is too easy. If it were 5%, that question might be too hard. It needs edited.
Or you wrote it wrong.
Because it's confusing or whatever. Yeah. But after, usually, not always, but usually you can see that there is not necessarily like an even spread amongst choices for the other distractors. There's usually like the correct answer is most often keyed as correct by users taking or approaching a question. But then there's another distractor that gets like second place as far as choosing goes. And I tend to call that the most attractive distractor. And it's less clear in this particular question, but I would say if you were scanning this quickly, perhaps, and maybe you were sick during your endocrine block, during second year, and you read this question, you might think, okay, panic attack, right? They always say in behavioral science or psychiatry, make sure you check the thyroid, because hyperthyroidism can be an organic cause of panic type symptoms, including tachycardia. So I could see somebody thinking, oh, okay, so this is probably something related to the thyroid. The thyroid was operated on, but all of that would be untrue. So I guess that thyroid surgery is not really a red herring. It's essential, but not because the surgery is on the thyroid, but like you said, because the anatomy of the parathyroid glands.
They didn't give the calcium, it'd be a much harder question. And I think that if the TSH was elevated was one of the options along with increased thyroxine, that I think would be actually a better question, because the TSH should go up after thyroid surgery, but you don't know how much it's going to go up, how soon, and maybe they poked the wrong thing so the thyroxine could be up. The fact that they gave you low calcium in thyroid surgery just makes like the PTH, it's like the PTH, right? Like that's like, the vignette was all that blah, blah, blah I talked about, right? Like the perioral tingling was great, but like blah, 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 low calcium thyroid surgery, I was done. Right, parathyroidectomy. And this is what I mean when I said I could take my ABIM exam in 2.5 hours, because I would do this, right? Like I would just hone in on now I probably got some wrong because
no one's perfect.
Yeah, well, no, but I mean, like, I wasn't like, oh, I don't know. I just, I picked what I thought the answer was. I probably was distracted a couple times, but overall it didn't matter because I passed.
Let's move on.
Next one.
A 27-year-old woman, Gravida 1, Para 1, comes to the OB clinic because of agalactorrhea, fatigue, cold intolerance, hair loss, and unintentional weight gain for the past year. She had placenta accreta during her first pregnancy with an estimated blood loss during the delivery of 2,000 cc's. Which of the following is the most likely cause of her symptoms?
I mean, I know the answer already too, right? She's got placenta accreta, blood loss, pregnancy. It's going to be Sheehan syndrome. Dysfunctional pituitary gland. So I'm going to look for low levels of the anterior pituitary and high levels of the secondary organ, or low and low. Right? So low TSH, low T4, low ACTH, low cortisol. Let's see what happens.
All right. So which of the following is the most likely cause of her symptoms? The answer choices are A, Addison disease, B, Cushing syndrome, C, Hashimoto thyroiditis, D, pituitary adenoma, or E, Sheehan syndrome. You are correct.
All right, good. But this is actually really hard, because Addison's, first, I'm surprised they use eponyms. I thought we were getting away from that. Addison's disease is a primary adrenal deficiency where you're going to have not enough cortisol be produced because of
a lack of all the adrenal. So no mineralocorticoids, glucocorticoids, or androgens.
Right. So Addison's cramps out, and that's actually could be with the huge hemorrhage. 2,000 cc's is a lot. So I guess you could think you might have killed off the adrenal glands, but I would be going after low blood pressure from the low cortisol and maybe some potassium abnormalities. They probably have to give you potassium abnormalities if they really wanted you to go after Addison's, even though that's not actually the common presentation. Cushing's is too much cortisol. That's weird. I mean, I think that if you thought that Sheehan's was associated with the pituitary adenoma, maybe you might think Cushing's syndrome or Cushing's disease, but hypertension, diabetes, hypertension. Hashimoto's, I think, was close because fatigue, cold intolerance, weight gain. But Hashimoto's is an autoimmune destruction of the thyroid, which wouldn't have anything to do with the pregnancy. And as soon as you said G1P1, I was like, Sheehan syndrome in my head.
Exactly.
If they give you G1P1 and it's like after delivery, I mean, it's going to be one of the complications there.
Yep.
And then
pituitary adenoma.
If you just got to that one and didn't read all the answer choices, that's technically not wrong. Sheehan syndrome is, a huge hemorrhage after delivery, and that causes essentially the necrosis of the pituitary. But
yeah, and I think that you bring up another good point too. So yes, they are trying to get away from eponyms, but all right, one thing when you study that you have to keep in mind is know what entities are called, like all their names. So Sheehan syndrome, also sometimes referred to as pituitary apoplexy. You could even just descriptively hemorrhagic necrosis of the pituitary gland. Like, know what the entity is, especially if there is some notable eponym that it's going to be hard to get away from, like Cushing's syndrome. Like, everybody knows Cushing's syndrome is, excess cortisol, and you're looking at a person with hypertension, central obesity, buffalo hump, poor wound healing, moon faces. That was always my favorite.
Which means acne, by the way. I don't think anyone ever explained that meant they're fat and have acne and stretch marks. And I was like, you purple, striae, moon faces. What does that mean? Like, well, they're fat and have acne.
Isn't that like so many things in medical education, though? Like we interviewed Emily Tan, who is an ortho resident and heads up white coat coaching, and she was walking me through fracture names like green stick fracture or a nightstick fracture, and I didn't realize that these terms actually kind of made sense. It was very educational, and I was like, wow, it took me 4 years of medical education and completely lost on me. All right.
So I do joke and say that the video where there's anesthesia versus ortho.
Yeah.
There's a fracture. I need to fix it.
Yeah.
That's actually what the medicine person says. There's a fracture. It needs to be fixed.
Right.
So the ortho person, it's got 27 different variables that I've never even considered.
They don't get enough credit.
It's true. Actually, I really believe that. They may not know how to do DVT prophylaxis, but they sure do know how to fix a hip.
Yeah. All right. So Addison disease, I would say one little fact to remember, though, about Addison's disease for step one is that, yes, it is usually an autoimmune condition, but uniquely, it can also be caused by Mycobacterium tuberculosis. That's I think a concept that shows up a lot in the step one review literature, if you will.
Most common U.S. is autoimmune. Most common worldwide is disseminated TB. Don't forget about Neisseria meningitis.
Waterhouse-Friedrichs and
yeah, look at that. Look. You pull that one out of your head? Or
I did, actually. Yeah.
Nice.
That one was tons of useless information that sticks with you from med school. All right. Let's move on. 24-year-old man comes to the clinic for his annual checkup. His past medical history is non-contributory. Blood pressure is found to be 152/78. The measurement is repeated and shows a similar result. Physical examination shows no other abnormalities. Lab tests show hypokalemia and low plasma renin activity. Which of the following conditions is the most likely cause of these symptoms?
Well, it's hyperaldo, so let's find out which one.
See, like
hypertension, hypokalemia.
Absolutely. All right. So if you weren't a board certified internal medicine physician, though, you'd have to read each of these, and you might struggle.
Yeah, let's read them out anyway and go through them, because I think it's going to help explore the system that I use to make that answer so concrete and obvious to me.
All right. So A, aortic coarctation. B, carcinoid syndrome. C, primary hyperaldosteronism. D, unilateral renal artery stenosis. Or E, extracellular fluid contraction, or volume contraction, we could say.
I actually have a video in the intern content which explains this pretty well. I used the Katrina switch, right? So you just draw a picture of a glomerulus.
Yeah.
At the JG apparatus, I've got a switch, only it's a Katrina switch. My house after Hurricane Katrina, when I bought it, a couple of the light switches were just down was on and up was off. And rather than remembering not like the ones that have to be congruent to be off, and if they're different, then they're on, like just one light switch, down was on, up was off. I mean, typical Katrina flip. And I use that system to measure the flow through the nephron. And if the flow is high, it pushes it to off. And if there's not a lot of flow through the system, it falls to on. And the JG apparatus makes renin. Renin makes Ang2. Ang2 tells a little fat hat on top of the kidney to make aldosterone. Aldosterone's job is to reabsorb sodium and kick out potassium. And then that's so the aquaporin channels can be inserted under ADH's influence to reabsorb water. Water follows salt. So as I heard this question, I said, okay, well, I actually wasn't sure what it was at first, but it was obviously hypertension. And as soon as you said hypoK, I mean, that's a buzzword. Hypertension and hypokalemia is hyperaldosteronism. But then the question actually got really good because it gives you a couple of reasons why there might actually be a bunch of reasons why there is hyperkalemia. So the idea with this system is if the flow to the kidney is low for whatever reason, then the switch will fall to on, which means renin will go up, Ang2 will go up, aldosterone will go up, and sodium's reabsorbed, potassium is lost in the urine. So hypertension and hypokalemia only tells me that it's an aldosterone-mediated process.
Yeah.
Aortic coarctation is going to prevent blood flow to get to the renal arteries. Most coarctations that people survive are past the great arteries, but are usually above the renal arteries. So our aortic coarctation could be a secondary hyperaldosteronism. So that would actually, like the blood flow to the kidneys will be reduced, and so renin will go up, Ang2 will go up, aldo will go up. The same thing is true of renal artery stenosis, right? You have a decreased flow to one of the kidneys. The flow is down, so the switch is on, renin up, Ang2 up, aldo up. So you have another secondary hyperaldosteronism. And even extracellular fluid contraction, I think what that's saying is it's a volume contraction being volume down. Yeah. That too would put the flow through the system to be low, so the system would be on, renin up, Ang2 up, aldo up. That's another cause of secondary hyperaldosteronism.
So you're looking, those three answer choices all have in common that they would...
Hyperaldo.
Yeah, they would increase or upregulate or whatever the renin-angiotensin system.
Right, but if you didn't know that system really well, and all you learned was hypertension, hypokalemia, as I did, all of them are right. Like all of them are hyperaldosterone states. The thing that separates this question to primary hyperaldosteronism is the renin, right? The low renin means that it must be a primary hyperaldosteronism because aldosterone is increasing the return of fluid and Ang2 is increasing, well, it's blood pressure and fluid thing. So the flow to the kidney is increased. So the flow switch is turned to off. So renin should be off and aldo should be low, but it is inappropriately elevated. And even in a test-taking strategy, if I saw three options were secondary hyperaldosteronism, I know they're all wrong.
Correct.
Right? They all mean the same thing, unless they gave me like a bruit in the abdomen or for
some specific differentiator, like an essential piece within the vignette to rule something in. And you have to look at those things. Those are like the, not buzzwords, but patterns or like highlights of a disease that you just have to kind of know intimately to and be on the lookout for within reading the vignette. But all right, what about carcinoid? Like, what are some good things to know about carcinoid for step one?
For step one, I mean, 5-HIAA in the urine. Carcinoid comes from the lung and the liver. Lung and the gut. It only causes problems when it metastasizes to the liver. Since the lungs and the liver break down carcinoid, when you have a intestinal carcinoid, it's going to release whatever it does into the bloodstream. It's going to cause right-sided cardiac fibrosis broken down by the lungs, so you don't get anything problem with the left side. And if you have a lung carcinoid, you're going to release the stuff into the bloodstream back to the pulmonary vein into the left side. So a pulmonary carcinoid will have left-sided cardiac fibrosis. And then the carcinoid stuff is flushing diarrhea and cardiac fibrosis. I'm not sure how it influences the renin system at all, actually.
I guess maybe stimulated to increase vascular tone. Yeah, because you're flushing, you'd have like hypotension, tachycardia, you're volume depleted, diarrhea.
Yeah, that might be a stretch to get you to secondary aldosteronism. That would be a really good question, actually. No, all of those are some way of secondary hyperaldosteronism, and they gave you a low renin. So you could flip the renin to be elevated, and then you'd have to use the physical exam to find out which one is the right answer. Coarctation with the low blood pressure on the feet, cold feet. Renal restenosis with a Brewy. Extracellular fluid contraction, some reason to be volume down, and flushing, cardiac fibrosis, and wheezing to be carcinoid. And that would be this is a great question because you can mold it so easily. All of these answers can be made correct if you change
one or two little things. There are people all around thinking of really oh man, this would make a great question. So on this podcast, hopefully, you are hearing 2 years before the types of questions that will be on board exams that hopefully the NBME writers will just steal from us.
This is exactly why I tell people that they need to read the answer explanations and really engage the answer choices beyond whatever Qbank they've gotten has told them. Like that exercise we just went through not only helps you figure out the test taking strategy, but also solidifies the illness script. If you didn't know coarctation was supposed to have rib notching and lower extremity hypotension, well, now you learn it. And so this is one of the reasons why I say board exams matter. I think that USMLE is an awful way to place people into residency, but studying for the USMLE, even the step 1, forces you to learn stuff you really don't want to learn, but you really should know. So that when you're done, you don't remember exactly what happens with thyroglobulin, MIT, DIT, T3, T4, but thyroglobulins made in the thyroid, and it also makes T4, right? So by the time you recoil from the extreme amount of learning that you've done, your illness scripts are pretty well made, and you can actually use that clinically or to grow your knowledge in whatever field you choose.
Yeah, absolutely. And this starts part 2 of the original interview with Dr. Williams. A 47-year-old female presents to the clinic with a chief complaint of nausea, vomiting, and vertigo. In addition, she has had amenorrhea for the past 6 months. Ophthalmic examination shows bitemporal hemianopsia. Brain MRI confirms the presence of a pituitary tumor. Which of the following substances is likely to be elevated in this patient?
All right, so read me all the answer choices. I cannot predict this one.
I bet you will. Once you'll be like, okay. A.
Okay.
Dopamine. B. Estrogen. C. Growth hormone. D. Melatonin. Or E. Prolactin.
All right. So this is bitemporal hemianopsia is usually found in men because they get pretty big, and in women they're usually microadenomas that only have amenorrhea and galactorrhea. But okay, let's buy into it. They're giving you the full clinical vignette, all of them together. Amenorrhea and galactorrhea point me to a prolactinoma, so I'm going to star that one. Dopamine, that has to do with Parkinson's or schizophrenia. It doesn't come from the pituitary. Same thing, estrogen does not come from the pituitary. That would be out. I guess supposedly you could have an FSH, LH secreting tumor, but those are really rare.
Yep.
Growth hormone causes acromegaly, and that could also is a fairly common pituitary tumor. And melatonin's out. So what do we have? We've got this might be just a prevalence question, which is more common, prolactinoma or acromegaly. And I do believe it's prolactinoma, which also goes along with my amenorrhea.
Correct.
So I'm going to say E, prolactin.
You are right. And she did have an MRI that confirmed the presence of a pituitary tumor. So I guess at the medical student, second year level, right? In my mind, pituitary tumor with bitemporal hemianopsia and amenorrhea plus or minus the galactorrhea is going to be a prolactinoma.
Yeah. Just prevalence-wise, you could have a pituitary adenoma. Acromegaly is common enough where it was a competing factor, but they would have given you the growth hormone symptoms.
Yeah.
Hepatomegaly, rings that don't fit, and spacing of the teeth, and they didn't give any of that. So I was debating whether this was a prevalence question or if the symptoms they gave me were real, and I went with they're real. This is the step 1 question. They're not going to include amenorrhea and want growth hormone and leave out the spacing of the teeth and hepatomegaly. They're not going to do that to you.
So how would they test prevalence? I would say you could have a 47-year-old woman come to the clinic with headache. That's it. MRI, show some vital signs, maybe say some other, fluff. And then the brain MRI shows the presence of a pituitary tumor. Which of the following substances is likely to be elevated in this patient? And then each substance could be a potential adenoma. Because, really any pituitary hormone could be elevated based on the cell that is transformed, right? So you could have an FSH producing adenoma. You could have a growth hormone producing adenoma, prolactin, or TSH producing adenoma. But the most common is going to be prolactin.
Prolactin, right. That's exactly it. If they gave you bitemporal hemianopsia, they would have justified the MRI. But if they left out the amenorrhea and just gave you the nausea, vomiting, vertigo with headache, that was all to lead you to get to MRI. And the MRI shows an anterior pituitary. And so what's most likely to be elevated is really asking what were most common anterior pituitary tumor, and that is one of prolactin. And you just have to know prevalence. That would be a mean question. I think the step one's not going to do that. I think they're going to give you symptoms. Yeah, that's too much.
Do you think it's safe to assume that at the second year level, you can consider pituitary adenoma, which is a general term, as equivalent to a prolactinoma for most purposes?
I actually have my endocrine lecture set up so that I include acromegaly. I think my own way of categorizing, might have actually thrown me off, because those are the two that I teach about. Those are the two that are clinically relevant. Yeah. And prolactin is by far more common. And I think I tricked myself because of the clinical medicine. You're right. Prolactinoma and pituitary adenoma, just by prevalence, really should be linked together, unless they try really hard to give you competing physical exam information or laboratory stuff. That you should just don't jump right to that, right? Yeah. I would say yes. Pituitary adenoma equals prolactin. This is going to get you 95% of the cases. And if you need to get that question right, that is a trick. You're going to get a 275 if you get it right. So it's safe to say pituitary adenoma, prolactinoma.
Yep. Equate them. Oh, the other thing is bitemporal hemianopsia is something I think is a very high yield thing to know what that means, but essentially, the tumor would push on the optic chiasm, and since the fibers of each eye that are responsible for the lateral visual fields, the temporal visual fields, cross at the optic chiasm, you cut both those out, and essentially you've got almost like tunnel vision. It's useful to look and memorize and know and understand the anatomy of the visual pathways.
And just as you did, though, the anterior pituitary adenoma is prolactinoma. If you've got bitemporal hemianopsia, you see those words, tunnel vision, loss of the lateral fields. They can describe it any way. If you see bitemporal hemianopsia, it's a pituitary tumor. Yeah. You could skip everything else and just jump to the MRI and then start looking for what is the tumor that's producing this. It's they try to get away from buzzwords, but as you develop illness scripts of diseases, there are buzz phrases. There are things you should look for. Like, that's good clinical medicine, right?
Exactly.
If someone comes in with toe pain, it's probably not an MI. If they come in with crushing substernal chest pain that radiates down their arm and they're a dude, it's an MI. It's okay to do that. Right. So I think that things like bitemporal hemianopsia, anterior pituitary adenoma, like all those things can be one-to-one linked with these buzzwords.
This one's good. You're going to enjoy this one. All right. A 35-year-old woman comes to the office because of headache, increased sweating, and intermittent stabbing pain in her right flank. She has no chronic medical conditions, does not take any medication, does not smoke or use other drugs or alcohol. Her family history is significant for thyroid cancer on her maternal side. Physical examination shows that the patient is pale and appears anxious. Her heart rate is 120 beats per minute, and her blood pressure is 210/120. Which of the following diagnoses is most consistent with this presentation? Do you want to think through this, or do you want me to?
Oh, I know this is my first patient in residency. I know. We'll do the exercise. Go ahead and read them off, and then I'll explain.
A, anxiety disorder. B, essential hypertension. C, hyperthyroidism. D, multiple endocrine neoplasia type 1. Or E, multiple endocrine neoplasia type 2.
That is brutal. That's right? A tough question, right?
I know.
So my first patient in residency ended up being an MEN2B. She was 35 years old. She came in with stabbing left flank pain and a headache. Blood pressure was 210/120. She was pale, diaphoretic, tachycardic. And I stumbled on the diagnosis, right? I got a CT scan of the head to rule out a head bleed. She didn't have that. And eventually I got down to, I thought it was just going to be pheo. And then pheochromocytoma led me to take a look at her family history. She had a thyroid cancer unknown, and then I ended up diagnosing her with MEN2B. So this is an unfair question because literally this is the patient, my first patient of residency as an intern. I was seeing her independently on the Apollo service, which means that both I and the resident were seeing people independently, and it took me about 5 days to make the diagnosis. And I got at SHM, Brad, who runs the whole mystery diagnosis thing, was like, "Hey man, can I use your case for mystery diagnosis?" I was like, "Yeah, I guess, sure, whatever." And he's like, "You'll never see one of these again, right?" And I've been searching ever since. Yeah, so this is totally unfair. I mean, it's MEN2B. But let's just go through the question.
Again, I will repeat, this was totally not scripted.
Yeah, that's right. Totally not. It's amazing. So anxiety disorder is a great distractor, right? Young woman, no history. She
easily ruled out though because of the blood pressure.
Right. I mean, even if the blood pressure was a little high, I mean, they're selling the blood pressure, right? That is obviously pathological, over 200. Correct. Like, if it's just a little hypertensive, it could still be anxiety. But they wouldn't sell the severity of illness so hard, right? If it's a panic attack, they really want you to either rule out MI or to make the diagnosis of anxiety, it's got to be everything's cool. Yep. Right. But she's obviously sick with a high blood pressure, high heart rate. She's pale and diaphoretic, right? So that's not. Essential hypertension is also ridiculous. It should be a stable blood pressure that you see multiple times and should not be over 180 over 100. They've done away with the blood pressure limits for emergency, but this would definitely be urgency ranges. And on the test, 150 over 80 is hypertension, right? 200 over 120 is ridiculous hypertension that you should pay attention to and something's wrong.
Right.
So you see really high numbers. But I say that because I see people who are walking around in Louisiana with blood pressures pretty close to this, and that's just their normal. But on the test, you see someone this high, done deal. Hyperthyroid is a really good distractor because she has the family history of thyroid cancer. She's got tachycardia, hypertension, and even diaphoresis. All of that sounds like thyroid storm or hyperthyroidism at least. Thyroid storm usually is hypotension because her heart rate goes too fast. The thyroid cancer, most cancers don't cause hyperthyroidism. They cause hypo because they take over the thyroid, and the stabbing left flank pain just doesn't fit. So I almost chose that. MEN1, MEN2B. All right. They're both multiple endocrine neoplasias. They both have stupid stuff. So the MEN1 is the hard P's, which I think is pituitary, pancreas, and parathyroid.
That is correct.
MEN2B is going to have.
So, though, I would say, what do you do if you get MEN2A, MEN2B? Can you go through that? Or that's, I know that's rough.
Well, actually, it's actually really good step one content, though, because it's so irrelevant in clinical medicine, but it is so obvious for a test question. So MEN1 is the hard P's, MEN2A is the soft P's, and there's two of them, and one of them is medullary thyroid cancer, and one of them is the other one. Now, I don't really have a good organizer for 2A, 2B, and that's actually something that's really going to be testable at step one level. If you got something, I'd love to hear it.
I guess my approach to remembering these is to remember the one that's easiest to remember. And like you just said, and like Golian says, remember one and then the other one's the other one. And it's actually MEN2A, medullary thyroid cancer, pheochromocytoma, parathyroid adenoma.
MEN2A is pheo and thyroid cancer. MEN2B is pheo and thyroid cancer. 2A, parathyroid, A or para. And 2B is the other one, neural tumors.
Oh, that's right. Neural tumors. That's right.
Neuronal, yeah. So 2A is pheo, thyroid, 2B is pheo and thyroid, and the third one is different. MEN2A has parathyroid.
That's how you remember that. That's good. That'll work. Anything else for these things? Let's see. Okay, so if you hadn't been an intern yet and this is your first patient that will forever be burned into your mind, how would you rule in a MEN syndrome from what's given in the vignette? Over and above the hyperthyroidism. So, I mean, yes, the flank pain doesn't fit for hyperthyroidism alone, right? But why does she have stabbing pain in her right flank? Because I see that as a centerpiece of this vignette.
So actually, I think they've sold pheochromocytoma really well. I think they've done a poor job of selling an MEN syndrome, but they didn't give pheo as an option. If they gave isolated pheochromocytoma, I would have picked that.
Yeah.
Because other than the thyroid cancer, they didn't tell me she has risk factors for multiple endocrine neoplasia. We talked about the P's already, but the stabbing left flank pain, that it usually actually doesn't present that way, but they're saying, hey, something is wrong with the adrenal kidney area. Left flank means kidney ureter.
Maybe kidney stones.
Right. Yeah. Right. So kidney stones. So actually, that's what I thought my patient had. Actually, when she first came in, I thought she just had a brutal response to pain, and she actually had microscopic hematuria. So we actually got a non-contrasted CT of her abdomen, which did not detect the adenoma, which really was distracting on that patient. So the question though was saying, hey, something is wrong with the kidney adrenal area. And then they give you 4 of the 5 P's of pheo. So that's really quickly directing me to pheo. Then they gave you the history of thyroid cancer, which says, okay, that's 2 out of the 3 of the MENs. But still, if they didn't give me a thyroid abnormality or a thyroid nodule or something else, I really would have jumped to pheo and not MEN2B. But I think that's actually the equivalent answer because the only one of the 5 of MEN2B is pheo. So if you saw the pheo and didn't find it in your answer choices, I think it would be useful to then re-engage those answer choices and find out which one of them includes pheo, and that's MEN2B.
Yeah, and 2A too, right?
Right. Yeah. Sorry.
So just
of the 5.
Yeah.
Yeah. Of the 5, it's MEN2B, but they could not have put MEN2A and 2B together. That's just ridiculous. That's just someone being mean. This question, really, the educational objective here was which of these syndromes is pheochromocytoma part of?
Yeah, exactly. So that helps you rule out the MEN1. There are going to be certain concepts that you do kind of have to memorize. And part of that is going to be the distinction between MEN1 syndrome and MEN2. And the pheochromocytoma is an essential part of the MEN2 picture over and above MEN1. And I liked that. Hard P's. I never thought of that for MEN1. Pancreatic, parathyroid, and pituitary.
Yes, indeed.
And you're ahead of me. I could have learned this from you.
OnlineMedEd.org/endocrine/MEN-syndromes. But seriously, actually,
make that a
the
hashtag.
hard P thing worked. 2A, 2B thing, I had to go to my site to look it up, right? So people who are listening, I had to look it up to know that stuff. So it's not possible that you know everything about everything and retain everything about everything. It's just, it's ridiculous.
All right. One more. A 17-year-old comes to the clinic because she has not undergone puberty yet. She emigrated from another country 2 years prior, and her mother underwent puberty at 12 years old. Her vitals are normal, including a temperature of 37 degrees Celsius, which is 98.6 Fahrenheit. Pulse is 82. Respirations are 12 per minute. Her blood pressure is 162/94. Physical examination shows a female with Tanner stage 1 development of the breasts and no pubic hair. Pelvic examination shows ambiguous external genitalia and a blind vaginal pouch. Laboratory studies show a potassium of 3.1, and further studies show a decreased serum androstenedione. Abdominal ultrasound reveals bilateral masses within each inguinal canal and enlargement of the adrenal glands. Which of the following is most likely deficient in this patient? And feel free to rewind the elements of that vignette before we discuss that for the listeners. There's a lot in there. This one is difficult to do, over audio, I think, especially. But I would say that there are a lot of vignettes that are this dense on board exam questions. So you've got...
This is why you read the question first. I bet they're going to be 17, 21, 19 hydroxyprogesterone.
You are close. The answer choices. So, all right, we'll just keep our usual format and go through these. So the interrogatory, which of the following is most likely deficient in this patient? A, 11-beta hydroxylase. B, 11-deoxycorticosterone. C, 17-alpha hydroxylase. D, 21 hydroxylase. Or E, brain natriuretic peptide.
All right. So this is actually a perfect reason why you read the question and the options first, right? If you see 17 hydroxy alpha, 11 beta, 11 deoxy, 21 that's congenital adrenal hyperplasia, and they're testing you on like the cortisol pathway.
Yeah.
And actually, I think most of this was bad. And so I actually have an approach to primary amenorrhea where I'm looking for external genitalia development and also
which is a great, very high yield video, and I think it would be actually super relevant to go through these concepts, even for the step 1 level, even though you kind of intended it for third years, correct?
Right, but the endocrine stuff in that lesson actually is pretty relevant because it helps you get here. It doesn't get down to this level of detail, but when you started off primary amenorrhea, I was listening for whether she was going to have anatomy, that is the axis development, pubic hair and breast development, and what her anatomy was going to be, whether she has a uterus and vagina, fallopian tubes, and try to figure out that way. And so she definitely had no breast development and no pubic hair, which means the axis is deficient, right? So it's an endocrine problem. I wanted to see if she also had some sort of anatomy issue, and she seems to have a blind vaginal pouch, which seems to mean that she's got something wrong with anatomy as well. And broken anatomy, broken axis is kind of weird, but then they kind of gave you the answer, right? So if you just ignored the whole beginning, I was thinking about Kallman syndrome. I was thinking about Mullerian agenesis and testicular femization, which I think is androgen insensitivity syndrome now. I was kind of like, going through all these. I was like, oh my God, this is going to be hard. But then they told you at the end that there's bilateral masses of the inguinal canal and the adrenal glands are bilaterally hypertrophied, right? So the whole blah, 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 blah came down to there's adrenal hyperplasia and she has primary amenorrhea. The ambiguous genitalia is useful because, the body's not sure which one she's got, testosterone and estrogen. And so I would just say this is a cortisol pathway issue. The diagnosis is congenital adrenal hyperplasia. And I really don't know the answer at all because I haven't engaged this stuff in a long time. But I think the 17-hydroxy is in the urine, so it's going to be the 21-hydroxylase, which is correct. But I literally am just guessing. So even though I think I made the diagnosis correct on the vignette, I have no idea what the answer is, which happens sometimes.
So the answer is 17. So she has a deficiency of 17 alpha hydroxylase, which was choice C. And the reason is CAH from 17 alpha hydroxylase is characterized by an inability to produce the glucocorticoid and androgen hormones, right? And a resultant increase in mineralocorticoids, which I think is probably what they're trying to get at with the elevated blood pressure, likely due from sodium retention, and her potassium was a little low, 3.1. So
I got both the diagnosis and the answer wrong. All right, good job. That's a really hard question, though, and it's almost like so. The educational objective here is: do you know the cortisol pathway, and can you find the area that's broken? I think if I started there, I would, if I had it in my head, which I don't, I would draw out the cortisol pathway, at least rough it, and see which of the deficiencies. I actually didn't even latch on to the hypertension and hypokalemia, even though we literally just talked about it. I missed the hyperaldo state, and then got totally distracted by the amenorrhea and the bilateral adrenal glands. I knew it was congenital adrenal hyperplasia, but I think I totally botched the explanation of what's going on here endocrine-wise. And that just goes to show you, sometimes you're going to get a question wrong. It's totally okay.
Well, okay, so we did, I think we got through 5 or 6 of these. You only got one wrong. If you get 80% correct on your step 1 exam, you're probably going to get a pretty good score. All right, so a 17-year-old boy comes to the endocrinology office for an evaluation of delayed puberty. He says that his sense of smell has been impaired since childhood. His vital signs show no abnormalities. Physical examination shows sparse facial, pubic, and axillary hair, rounded body contour, underdeveloped genitalia, and small testes. Sounds like a string of insults that would be slung at someone. Laboratory studies show decreased LH and FSH serum levels. Serum testosterone is also decreased. Prolactin is 18 nanograms per milliliter and normal is less than 20. TSH is 2.0, which is normal. Which of the following is the most likely diagnosis? A, constitutional delay in puberty. B, hyperprolactinemia. C, Kallman syndrome. D, Klinefelter syndrome, or E, panhypopituitarism.
All right. They have the word they didn't say anosmia, but trouble with smell. Pretty much a Kalman syndrome already.
Yeah.
So
like,
I'm just going to mark that one. Yeah.
Like, I can't think of another reason why that would show up on the boards, like anosmia or difficult sense of smell. Like, but I mean, besides like, I don't know, they have like congestion or maybe like a random weird infarct in the smell center of the brain. But like Kalman syndrome, right? Like anosmia, difficulty smelling, you really need to be thinking about Kalman syndrome.
But I think it's a good point, though. Again, it's why you read the question and the answer choices. If there is anosmia and everything's about postnasal drip, sinusitis, pharyngitis, it's going to be about stuffy nose.
Right.
If it's delayed puberty, then you're right. You're delayed puberty and anosmia together. We're done. But I think it's actually a useful system to work through, right? Because this one really tests your knowledge of the anterior pituitary down to the testes to growth. And the whole point is, and I actually usually think about this in terms of a girl. So this was like functionally difficult for me because they talk about it in the way of puberty in girls. FSH and LH are supposed to stimulate the testes to make testosterone. And I'll just say testosterone. That's easy for it's a guy, and that'll induce puberty. So therefore, since LH and FSH are low, and then testosterone is low, it means that there's nothing driving the production of testosterone.
Or hypogonadotropic. Hypogonadism is how we think about this in OB.
Yeah, good. I mean, that's actually the right name. Yeah, I'm much more simple than you guys. You start to pull out Latin on me or something, like a dermatologist.
Well, I mean, but it brings up a good point, because what is Kalman syndrome? It's hypogonadotropic hypogonadism, and maybe they don't say Kalman syndrome, and if you aren't able to dissect and define what that term means, which I think you're about to do here, you might get it wrong. And that would suck if you knew the answer, but they just didn't give you, the
right word. Yeah,
maybe they'd say
serum immunofixation, man. I knew it was multiple myeloma and I chose the wrong answer. Or I didn't know the damn word they were using.
They've got like hypergonadotropic hypogonadism, and you're like just sitting there. Is it hypo or hype? Is it hypo or hyper? Is it hyper? Like I could see someone getting confused. So, I think you were about to describe or explain that.
And that's actually the danger of just memorization, right? If you had a table you put together for Kalman syndrome, you'd get it wrong. You wouldn't remember. You're stressed out on test day. You totally screw it up. But if you have the system, anterior pituitary makes FSH and LH, stimulate the testes to increase the value of testosterone. And testosterone is supposed to feed back on the anterior pituitary when testosterone is made to turn off FSH and LH. What you'd expect for puberty is an increase in LH and FSH and an increase in testosterone. But here you've got decreased LH and FSH. So low, hypogonadotropic. Gonadotropic stuff comes in the pituitary. And then low testosterone, gonads, hypogonadism.
Yep.
And so what I expect to see is one of those to be elevated. But since they're not, it means that the primary issue is hypogonadism, but the issue comes from the anterior pituitary. The fact that the prolactin and TSH is normal, it means the rest of the anterior pituitary is working. That makes a constitutional delay a really attractive answer, right? Because it sounds like the axis just hasn't started yet.
Yeah.
But unfortunately, at 17, that's no longer constitutional delay. If the age were different, like 13 or 14, that would be constitutional delay in my mind, but without the anosmia, of course. So The fact that he has anosmia and a functioning rest of his anterior pituitary pushes me to Kalman's, but constitutional delay, make him 15 and have no anosmia, I think that would count as constitutional. The panhypopit, normal prolactin and TSH, okay, that's that right there, and he has no reason why. Again, that's the Sheehan syndrome or some sort of infarct.
Yeah.
Hyperprolactinemia would be tough in a guy, amenorrhea, galactorrhea in women, bitemporal hemianopsia in a guy, but hyperprolactinemia does cause problems with the axis, so maybe that would actually be a reason why he might not be getting his growth spurt. And I missed the fifth option altogether because I heard anosmia. I stopped listening.
Yeah. So C was the correct answer, Kalman syndrome. Then we had D, Klinefelter's, E, panhypopituitarism.
Klinefelter's, right. So he'd be tall and lanky and have a weird genome. And I actually, XXY, I know they're tall and have some problem with their gonads, but they're hypogonadism. But if he hit puberty, the FSH and LH would be elevated, trying to tell the testes to turn on, but they wouldn't turn on. So in Klinefelter's, the LH and FSH should be up, not down.
Yep, that is correct. See, I have to think about this too, like as I go I go through. But that's perfect. I mean, that's what you should do. You should be able to think through what these things mean. Panhypopituitarism was the last one. So why isn't everything's wrong with
right? Yeah, the normal prolactin. Oh, actually, there's normal prolactin. That's why it's not hyperprolactinemia. Duh. Right? It actually have a normal level. And then panhypopit, the TSH would be also abnormal. Panhypopit supposed to be everything's busted, and it's only two things. So it's just the axis, not everything else.
So Kalman syndrome, hypogonadotropic hypogonadism, anosmia. It's a deficiency in the GnRH secreted by the hypothalamus. Remember that for the boards. You can take that with you to test day. In your mind, you can't actually take anything that says that or a recording of that in with you on test day. Please don't, in fact, because
leave it in your locker if you do.
Yeah, leave it all. All right, Dustyn, thank you so much for your time and being subjected to that pimping session. You did phenomenally. If you took step 1 today, you'd at least get a 270, at least.
I would maybe pass, actually, but yeah. Thanks for the kind words. I'm sure they're going to throw some mitochondrial DNA stuff at me, and I won't know what the hell's going on. But yeah, and this was actually kind of fun. It's just I was worried about it when I walked in. I didn't prepare anything, and I was hoping that my test taking skills would get me through. And sure enough, for the most part, they actually work.
So there you have it. That truly is a best of the ITB podcast, one of our most popular episodes. And for those of you who stuck around to the end, thank you. I want to tell you about a kind of a fun thing we're doing. So this is going to be a fake USMLE question campaign, and we're tying it to a contest. So from now until July 15th, head over to Twitter, go to my page @BoardsInsider, look for the pinned tweet. What we're doing are fake USMLE questions. So here's an example. If Deadpool were in a USMLE question vignette, his most likely diagnosis would be A, dissociative identity disorder, B, bipolar disease, C, antisocial personality disorder, or D, other. So here are the contest rules. You want to tag the character on Twitter. For instance, Deadpool is @DeadpoolMovie in the question vignette, and just set it up like if the character were in a USMLE question vignette, his most likely diagnosis would be, and then make a Twitter poll, pick 4 answer choices, and tag Inside the Boards, as well as Gomerblog. That's @BoardsInsider and @Gomerblog. And then finally, use the hashtag FakeUSMLE. The most creative fake USMLE question will get a 1-year subscription to our All-Audio Qbank for free. We'll have fun while doing it, maybe learn something, I don't know. It was just something that I thought would be a lot of fun, and you can also do it on other social media, I guess Reddit, Facebook, and Instagram, where on each platform we are @InsideTheBoards, or you can just send us an email to info@insidetheboards.com if you would like to contribute to the fake USMLE campaign. Just wanted to thank Rao Reynolds and Enter Shikari for letting us use the track Live Outside off The Spark, their new album, about which Rao said, "What I was trying to do with this album in marrying the personal and the political is to ensure that human vulnerability is laid bare and to not be afraid to speak about emotions. Plus, this album is a little lighter than what you heard previously with the song Anesthetist. At any rate, check out entershikari.com.